Hey everyone, so basically we're very lucky to have Dr. Daniella Kadian-Dodov here. Dr. Kadian-Dodov is Assistant Professor of Medicine at the Icahn School of Medicine at Mount Sinai in the section of Vascular Medicine. She's a member of the Diagnostic Laboratory Michael Vascular Institute and the Maria Jose and Henry R. Kravis Center for Cardiovascular Health at the Mount Sinai Medical Center. She graduated from NYU and received her medical degree from the Oregon Health and Science University in Portland, Oregon, and then completed her internal medicine residency at the Icahn School of Medicine at Mount Sinai. She then went on to complete a vascular medicine fellowship under the tutelage of Dr. Jeffrey Olin at the Icahn School of Medicine at Mount Sinai. She's well versed in the management and care of patients with non-coronary vascular diseases, including fibromuscular dysplasia, peripheral artery disease, renal artery disease, venous thromboembolic disease, and other less common vascular diseases. So we're really lucky to have her today here to talk about a very interesting and controversial topic, which is submassive pulmonary embolism. So Dr. Kadian-Dodov, thank you so much, and I'll turn it over to you.
All right, thank you very much for having me back again so soon. I'm sorry for last week. I don't know what happened. But I'm going to be discussing submassive pulmonary embolism from the vascular medicine perspective. I will be discussing the evidence behind the use of thrombolysis and IVC filter placement, as well as the different oral agents available for anticoagulation, the duration of anticoagulation versus extended therapy options for these patients as well. And I thought we would use a patient as a roadmap for our discussion this evening. So this is a 51-year-old male who we saw last year. He presented to the ED following a syncopal episode when transitioning from sitting to standing. He had a true loss of consciousness and sustained a head abrasion during his fall. Additionally, reported he had been having some shortness of breath and not feeling quite right for about 2 weeks prior to this. He had no recent travel surgery or injury, no prior known venothromboembolic event. He had a colonoscopy a year ago that was notable only for some polyps. He was unable to provide a family history because he was adopted. He was a former smoker, a moderately heavy drinker. No medications, no allergies. And on arrival was tachycardic and normotensive, satting 96% on 2 liters nasal cannula and able to speak in full sentences. His exam was otherwise notable for mild bilateral ankle swelling with some varicose veins. Looking at his labs, his creatinine was 0.9. He had a good hemoglobin and platelet count. His AST and ALT were moderately elevated, LFTs otherwise normal. He had a borderline troponin and elevated D-dimer. So this was his EKG on arrival. Other than the tachycardia, which you can see in lead 1, there's a prominent S wave, as well as a Q wave and inverted T wave in lead 3. This is the characteristic S1Q3 T3 morphology that's associated with PE. And also in leads AVR and the precordial leads, you can see that there's an RSR prime waveform, which is indicative of right bundle branch block, all of this indicating and signaling evidence of RV strain. So a CT angio was ordered. Let's scroll through this here. Oh, sorry. Okay, so going down, you'll notice that almost immediately there's a large amount of clot burden in the main right and left pulmonary arteries, extending out into the segmental and subsegmental lobes. In addition, as we go down, although this is not a gated study, you can appreciate that the RV appears larger than the LV. This is the echo on presentation. This is an apical 4-chamber view. We have, oh no, sorry. Okay, try this again. Apical 4-chamber view. Right ventricle, left ventricle, right atrium, left atrium. You can see that the right ventricle is moderately dilated as compared to the left ventricle. It appears larger in size, which it should not be. In addition, the septum is flattened and it's moderately dyskinetic here. This is a duplex of the distal right femoral vein. You can see that it appears dilated. There's echogenic material within. It's not filling completely. In addition, it's not compressible, consistent with acute thrombus. And the transverse cut of the popliteal vein, which appears nearly twice the size of the adjacent popliteal artery, again with echogenic material within, consistent with acute deep vein thrombosis. So this is a submassive PE. To give a little bit of background, pulmonary embolism contributes to nearly 30,000 deaths in the US each year and 200,000 hospitalizations. We classify patients into risk groups, which helps guide our clinical decisions on therapy. So massive or high-risk patients have RV strain with hemodynamic compromise, namely hypotension. This is associated with the highest in-hospital mortality rate of greater than or equal to 15%, and thankfully represents a small proportion of all PEs, around 5%. Submassive PE, which our patient has, is RV strain without hemodynamic compromise. It accounts for up to a quarter of all pulmonary emboli and has an associated mortality of 3 to 15%. And then our low-risk patients with intact RV function and normal blood pressure have an excellent prognosis when treated with anticoagulation alone, and many are treated successfully as outpatients today with the new oral agents. Our goals of therapy are to reduce the mortality risk by stabilizing the clot and preventing further pulmonary embolic events. And we accomplish this through anticoagulation and in the right setting, thrombolysis or IVC filter placement. We'd also like to prevent any long-term complications for our patients, including chronic thromboembolic pulmonary hypertension, which is actually not all that rare. There was one prospective long-term follow-up study looking at the incidence of chronic thromboembolic pulmonary hypertension in 223 patients with acute PE and no history of a clotting event. And out to 2 years, there was a 3.8% incidence of chronic thromboembolic pulmonary hypertension in this population. So this is a pathologic specimen of a patient who underwent the treatment of choice for chronic thromboembolic pulmonary hypertension, which is pulmonary artery thromboendarterectomy. You can see a massive clot burden that's outlining the pulmonary arterial tree. So in terms of what the guidelines in medicine tell us about thrombolysis, we look to the American College of Chest Physicians and then the American Heart Association, both of which are in agreement that patients with an acute massive PE and hypotension should be treated with lysis if they have an acceptable bleeding risk. They're also in agreement that patients with low risk or with low risk PE should not be lysed. Now, when we get into the submassive PE category, things get a little bit fuzzy in terms of which patients we should or should not treat. The guidelines tell us that we should treat those that we think are going to have an adverse prognosis and have a low bleeding risk. But there's no guidelines in terms of determining or identifying these patients. And then finally, catheter and surgical embolectomy and thrombolysis should be reserved as rescue therapy for patients who either do not respond to systemic lysis or are thought to likely not do well with systemic lysis. Again, no guidelines in terms of determining who these patients may be. And when we look at mortality rates with RV dysfunction, studies, including the International Cooperative Pulmonary Embolism Registry, have shown us that 30-day mortality rate doubles in patients treated with anticoagulation in the setting of RV dysfunction as an independent prognostic factor. Now, our prospective data of submassive PE in patients treated without thrombolysis estimate in-hospital and 30-day mortality rates to be about 1 to 5%. Within the same range, intracranial hemorrhage rates in patients receiving thrombolysis is about 2%. Now, again, the International Cooperative PE Registry studied about 1,000 patients and looked at how these patients did over time. And in 80% of patients with pulmonary hypertension who were treated with anticoagulation alone had normalized RV systolic pressures on follow-up echo at 6 months. But 27% of patients on anticoagulation alone who had initially no pulmonary hypertension developed new pulmonary hypertension, as well as about half of them had New York Heart Association class symptoms of greater than or equal to 3. Now, the Constantinides trial was a landmark prospective randomized controlled trial which looked at 256 patients with PE and RV dysfunction as identified by echo or EKG. Patients were excluded if they were hypotensive or had a massive PE or any contraindication to lysis. Patients were randomized to heparin or heparin with alteplase, and the outcomes that they looked at were in hospital death, need for escalation of treatment, recurrent PE, major bleeding, and stroke. And you see is that there's a reduction in the composite primary endpoint in patients with heparin, receiving heparin plus alteplase as compared to heparin with placebo, although this was really carried by an escalation of treatment in patients receiving the heparin only. Namely, they needed a higher amount of catecholamine infusions and secondary thrombolysis. There was no significant difference in death in either of these groups, as well as no significant difference in major bleeding, although this is a small population. Now, the follow-up study to the Constantinides trial was the PITHO trial, which looked at over 1,000 patients with intermediate risk PE. Patients, again, were randomized to lysis or anticoagulation only. There was a reduction in the composite primary outcome in patients receiving lysis as compared to anticoagulation alone, although this was, again, carried really by hemodynamic decompensation, and there was no significant difference in death from any cause between the groups. This benefit was offset by an major bleeding, as well as in stroke into receiving lysis. In addition, a subgroup analysis of patients over the age of 75 years showed a trend towards less benefit with thrombolysis and a higher rate of bleeding in our older patients, which is not all that unexpected, but notable. Now, low-dose lysis is attractive, namely because the lungs are particularly sensitive to thrombolysis, and we may lower bleeding rates for our patients. So the MOPPET trial looked at patients with symptomatic PE, not necessarily RV dysfunction, and again randomized them to anticoagulation alone or anticoagulation with lysis. They used a quote-unquote safe dose lysis, which was a half-dose TPA. And the primary endpoint at about 2 to 3 years of follow-up showed a reduction in pulmonary hypertension in patients receiving safe dose lysis versus the control group. In addition, although not significant, there was a trend towards a reduction in recurrent pulmonary embolism, and there was a reduction in the number of hospital days. There was no bleeding events reported, and there was no significant difference in total mortality between the groups. Catheter-directed lysis also is attractive because it's delivering a lower amount of lytic therapy to the patient. The ULTIMA trial looked at 59 patients with acute main or lower lobe PE and an RV to LV ratio greater than or equal to 1 on echo, sound-assisted thrombolysis, which is thought to increase permeability of the drug by disaggregation and separation of uncross-linked fibrin fibers. Patients received 10 milligrams per lung of TPA, so a max dose of 20 milligrams over 16 hours. And in this study, there was a resolution of pulmonary arterial pressures and improved cardiac index in patients who received the ultrasound-assisted catheter-directed lysis compared to heparin only. There was 1 death reported in the heparin-only group and 3 episodes of major bleeding. This trial is attractive because it was a standardized protocol and uses a modality that is relatively widely available, so maybe something that's applicable broadly. There are a few caveats to this study. The clinical outcomes were not evaluated for patients. They weren't probed for symptoms of dyspnea or heart failure. The ultrasound-assisted catheter-directed lysis has not been compared to other catheter-based therapies, and the study was not powered to draw conclusions regarding safety against anticoagulation alone. And recently there was a meta-analysis published in JAMA looking at 16 studies regarding thrombolysis in the setting of pulmonary embolism. 8 of these studies included patients with intermediate risk PE, and although most of the studies that I just presented showed no significant difference in mortality, when all the data was pooled together, there was a hazard ratio of 0.5 for patients who received thrombolysis as compared to anticoagulation. Looking at the absolute risk metrics of outcomes of major interest, again, there's a reduction in all-cause mortality for patients who receive thrombolysis versus anticoagulation with a number needed to treat of 60, being needed harm of 18. And then I'll just draw your attention to our over 65 group where the harm down to about 11 more cents we need to be aware of. Now, regarding IVC filters, what do the guidelines tell us? So the medicine guidelines tend to be a little bit more conservative as compared to the SIR guidelines. All of these bodies are in agreement that the contraindication coagulation resumed, the bleeding is resolved. There's a little bit less clear data in terms of the use of IVC filter in patients with acute PE and poor cardiopulmonary reserve. although most will lean towards recommending the use of IVC filter in this setting. The medicine guidelines state that IVC filter should not be used as an adjunct to routine anticoagulation and systemic lysis, whereas SIR says that with mid-level appropriateness, it may be a good adjunct for free-floating proximal DVT, thrombolysis, in our high-risk patients. The PREPIC study is the only randomized control trial that we have to date. This is the 8-year data, which basically is the same as the 2-year data that was published previously. This included 400 patients with quote-unquote high-risk DVT that was high risk for PE, so it was a proximal DVT. And these patients were randomized to permanent IVC filter or anticoagulation. And what we see is that in the filter group, there was a higher rate of deep vein thrombosis as compared to the no filter group, with a reduction in PE and no difference in mortality. Although I'll just point out that investigation for deep vein thrombosis was symptom-driven for patients, whereas PE was actively screened by protocol with imaging. Again, no difference in mortality between the two groups. PE-related deaths was only seen in about 1.8% of patients. This study had no information on RV function for these patients and excluded candidates for thrombolysis. Again, this also only looked at permanent IVC filters, which is a bit outdated today when we have retrievable filters available. There is a PREPIC-2 study, which is finished enrolling, although has not published data, and that's looking at the role of retrievable IVC filters for these patients. So it'll be interesting to see what that study tells us. With regards to IVC filter in patients with low reserve, there was a large retrospective analysis of over 2 million patients that was published to determine categories of patients with PE that might benefit from IVC filter. The study used ICD-9 codes to identify patients with PE, IVC filter insertion, thrombolysis, and then unstable by probing for terms like shock, ventilator dependent, etc. And patients were matched according to stability, thrombolytic therapy, and DVT diagnosis. And what we see is that our unstable patients seem to derive a more benefit from IVC filter placement versus no IVC filter placement with regard to in-hospital case fatality rates. And particularly our unstable patients not receiving lysis, they calculated a number needed to treat with IVC filter of 5 and a 35% reduction in case fatality rates. Although for all the patients that received lysis, there seemed to be somewhat of a benefit for IVC filter placement. So switching gears a little bit back to our case of a gentleman with submassive PE that was unprovoked, age 50. He was admitted to the coronary care unit at Mount Sinai. Our service was consulted for the question of thrombolysis and management. We recommended anticoagulation alone because he was hemodynamically stable, speaking in full sentences with good oxygen saturation. We requested a repeat echo in several days with the idea that we would reconsider thrombolysis if there was persistent RV strain on the echo. We did recommend a retrievable IVC filter be placed in this setting, which was done. So this is his repeat echo. Again, apical 4-chamber view. This is the LRV, now LV, which it should be, with good contractile motion. So from here, the next question would be, how would you really manage the patient? What's the optimal duration of anticoagulation for this patient with an unprovoked submassive PE, life-threatening event? And what agent would you use and how much? So in terms of guidelines regarding treatment, an unprovoked embolism at least 3 months, and thereafter you should conduct a risk-benefit analysis to determine whether or not extended therapy should be considered. They do say that in those patients with low to moderate bleeding risk, patients with an unprovoked venothromboembolic event, that's a PE, should be treated longer than 3 months. Bleeding risk, and then with a second extension is recommended. Our oral options for anticoagulant have really exploded over the last few years or so. This is an image of the coagulation cascade, which I think is the bane of everybody's medical education existence. But I think this picture really outlines well the location of action in the cascade for all of the oral agents available. Vitamin K antagonists, our factor Xa inhibitors, and the sole direct thrombin inhibitor, dabigatran. Now, looking at all these oral agents that are available, I think it's really important to note that there were quite a few differences in terms of how these studies were conducted. So dabigatran, again, our only direct thrombin inhibitor versus the factor Xa inhibitors that have been looked at, rivaroxaban, apixaban, and edoxaban, all were non-inferior to warfarin in terms of treatment for venous thromboembolism. I listed the trials here for you, so I wasn't able to put all the citations at the bottom. But there was, as I mentioned, differences in terms of how these studies were conducted. So dabigatran and edoxaban used a heparin run-in before starting the oral agent, whereas the Einstein and Amplify trials for rivaroxaban and apixaban did not. So rivaroxaban used an oral run-in of 15 milligrams BID for 3 weeks, followed by 20 milligrams daily. Apixaban 10 milligrams BID for a week, followed by 5 milligrams daily. There's a wide variation in terms of cost, Coumadin and warfarin obviously being the cheapest versus, upwards of $200 for the other agents. Not all agents are yet FDA approved. Currently, in terms of the novel oral anticoagulants, only dabigatran and rivaroxaban are FDA approved. Apixaban and edoxaban are pending and likely will be approved later on this year. And warfarin is the only agent that's really safe to use in patients with end-stage renal disease. The rest of these are not recommended in patients with a creatinine clearance of less than 30. Now, recurrent venous thrombosis is common following a first episode of symptomatic PE. This study looked at all comers with a first episode of DVT, 355 patients who were followed out to 8 years, and the cumulative incidence of recurrent venous thromboembolism was nearly 30% in this population, begging the question, should we really stop at 3 or 6 months of therapy, particularly for a patient with a life-threatening event, or should these patients be continued with either full-dose anticoagulation or some other secondary prevention therapy? There are some ways that we use to prognosticate this for our patients, one of which is D-dimer. So this is the PROLONG study. This study looked at 619 patients with unprovoked venous thromboembolism who completed 3 months of anticoagulation. D-dimer was measured 30 days after cessation of therapy. Patients with normal D-dimers were maintained off of anticoagulation. Those with an abnormal D-dimer were either resumed on anticoagulation or remained off of therapy. Outcomes were a composite of recurrent venous thromboembolism and major bleeding. And really the significant difference was in patients with an abnormal D-dimer level without anticoagulation versus either those with a normal D-dimer off of anticoagulation or abnormal D-dimer with anticoagulation. Patients with a normal D-dimer off of anticoagulation had a cumulative incidence of events that was not significantly different from those with an abnormal D-dimer who were maintained on anticoagulation. Similarly, factor VIII is another marker that we look at. So this study looked at 360 patients with first venous thromboembolic event who completed conventional anticoagulation. Factor VIII levels were measured 3 weeks after anticoagulation cessation. The primary outcome at 30-month follow-up was symptomatic VTE recurrence. And in patients with the highest factor VIII levels, greater than the 90th percentile, there was the highest rate of cumulative probability for recurrence of VTE. So both D-dimer and factor VIII levels are things that I order on my patients when I'm deciding whether or not to consider stopping therapy or continuing therapy. And it's a part of our regular practice in the vascular medicine department at Mount Sinai. Now, with regards to preventing recurrent therapy, a lot of things. dose has been examined both in the WARFASA and ASPIRE trials. This actually had conflicting data. So WARFASA showed a reduction in recurrent venous thromboembolic events as compared to placebo, whereas ASPIRE did not show a difference in recurrent events, but did show a reduction in composite MACE as a secondary endpoint. Now, low intensity warfarin, defined as an INR of 1.5 to 2, has been compared to conventional intensity 2 to 3. Not surprisingly, conventional intensity had a lower rate of VTE recurrence, and in this study there was no difference in bleeding. The PREVENT trial, which looked at low intensity warfarin versus placebo, showed that there was a reduction in VTE recurrence in the low intensity population, and there was no difference in bleeding for this either. This study also looked at patients with thrombophilia, factor V Leiden, and prothrombin gene mutation, and these patients had similar VTE recurrence rates. The dabigatran trial has been has been compared both to warfarin and placebo. Dabigatran compared to warfarin was non-inferior in terms of reducing VTE recurrence, and dabigatran had lower bleeding rates than warfarin. Dabigatran was better than placebo at preventing VTE recurrence with more bleeding. And then factor Xa inhibitors, rivaroxaban and apixaban, have also been looked at. I will point out that in apixaban, they looked at both low dose 2.5 milligrams BID as well as the 5 milligram BID dosing versus placebo. And the 2.5 milligram BID was as good as 5 milligrams BID in terms of reducing venous thromboembolic events with a lower rate of bleeding, which I think is attractive because you're potentially avoiding full dose anticoagulation, yet having equal efficacy in presenting VTE recurrence for those patients. So resuming back to our patient with the submassive PE who had resolution of RV strain on his repeat echo and an retrievable IVC filter placed. He was discharged. He, at 6-month follow-up, had resolution of his DVT on repeat duplex. He was maintained on Coumadin and then briefly lost to follow-up. He got plugged back into the system in 2012 and was referred by internal medicine to vascular surgery, who retrieved his IVC filter successfully, and then referred him on to hematology with a question regarding duration of anticoagulation. So anticoagulation was stopped by hematology. Factor VIII and D-dimer levels were low at cessation of therapy. He was transitioned to low-dose aspirin secondary prevention, and his D-dimers were trended out off of anticoagulation therapy and remained low. He continues to be prophylaxed with any flights or travel greater than 3 hours. Hematology actually referred him to our service for a second opinion, and we had a difference in opinion in terms of regarding extended therapy for this patient. We tend to be a bit more conservative, and for this patient with a life-threatening submassive PE, we were very hesitant to take him off of any kind of anticoagulation therapy. But that being said, he's doing well, so I think there's still a lot of question in terms of what the right move really is for these patients today. And with that, I'll stop. Thank you. Hopefully you're all still there so I can answer questions.
Thank you so much, Dr. Kadian. That was amazing. That was awesome. So much data out there. It's really great to hear it all in one place. And I definitely have to listen to your presentation multiple more times to absorb it all. But that was amazing. So just a question I had. The patient you presented, he had a submassive PE, and you didn't treat him with thrombolysis. Did thrombolysis, was that discussed at all? And would you have, if you had decided to do it nowadays, would you have chosen catheter-directed or systemic?
I think that's a really great question. So, I mean, definitely we discussed thrombolysis. We decided against it in that setting because he looked so clinically well, probably a function of his age because he was 50 and tolerating it much better than an older person would have. But we definitely did discuss it. We decided against it because of his stability, and we thought that if we repeated the echo and he still had RV strain in a couple days, reconsider thrombolysis at that time. That gets a little bit to what I think you and I were discussing before, which is kind of applying evidence-based medicine broadly versus using the art of medicine. And I think it's a very fine line and it's difficult to do. But that was the decision we made at that time. And luckily it worked out well for him. With regards to what I would do today, I think it's a little hard to say because I know he did well without lysis. But I think if I had to make the choice today, I would err, or I would be more likely to make a recommendation for half-dose lysis or potentially catheter-directed lysis. I think the half-dose lysis is very attractive. And, you know, I think particularly a very interesting question is whether or not we would be able to use half-dose lysis with catheter-directed therapies. So rather than 10 milligrams per lung, would people respond to 5 milligrams? That's not something that's been looked at as far as I know.
That's interesting. Wow. Everyone, if you have any questions, please feel free to go into the chat menu and type them in, and we'll ask them. So just another question I had in regards to all the thrombolysis trials. There hasn't been one trial really that's shown a benefit in mortality. It was only that meta-analysis. Is that correct?
Right. Yes, that's correct.
So is it because they weren't powered to show a benefit, or is it just it wasn't necessarily the primary endpoint, or?
I think it's a combination. I mean, in the meta-analysis, they were able to pool something like 22,000 patients. So I think definitely the power of the study made it more powerful to maybe see that signal that's too subtle to see in the size of trials that have been conducted today. I'm not sure, but it's interesting, and I think it again just shows that there's a lot we don't know.
Yeah. And then another question I had was, what is your preferred novel anticoagulant? Is there one that's your go-to anticoagulant that you use?
Yes. Yeah, so there is. I mean, today the only FDA-approved novel agents are dabigatran and rivaroxaban. I tend to lean towards rivaroxaban because it's once daily dosing as opposed to twice daily with dabigatran. So I find that my patients are more adherent to it and tend to prefer it a little bit more. That being said, we have quite a few patients with HIV at Sinai, and actually dabigatran is a better agent because it doesn't seem to interfere with the heart medications. So.
Okay, that's interesting. Wow. And then as far as catheter-directed thrombolysis, so if you had a patient that you're going to consider thrombolysis on, would you just go towards catheter-directed? I know at my institution, if we have a patient who has a submassive or massive PE, I guess they don't really usually even consider systemic thrombolysis. They go straight to catheter-directed thrombolysis. Maybe this is more of that, the art of medicine question, but what is your preference? I mean, there's definitely probably decreased rates of systemic, bleeding risk. You would think.
Yeah, there is. It's a difficult question. I think seeing the data from Moffitt that shows the half-dose systemic thrombolysis with, being equal benefit and not as high bleeding rates as the full-dose systemic lysis, I feel like I'm probably a little bit more inclined to lean towards that versus a catheter-directed therapy that would subject a patient who may or may not be unstable to a procedure. But, honestly, I'm not sure. I think it would be very case-dependent and specific in terms of what decision I might make. But that's kind of where I'm leaning, I think, today. Maybe different tomorrow.
Okay. Another question is, how do you choose when to stop anticoagulation in a low or moderate risk patient? And when factor 8 and DDAV are normalized, is it when factor 8 and DDAV are normalized, or is it a certain time after normalization?
That has more to do with their risk factors for the veto thromboembolic event. So if it's a provoked event and I can assign it to something like surgery, then I'll treat them for 6 months or 3 months even and be done with it and not worry about it. It's my unprovoked patients that make me really nervous, or the patients that have thrombi that's completely out of proportion to their risk. So like I had a patient who had a vein stripping and developed bilateral pulmonary emboli with no other risk factors, and she's young. You know, something like that would make me want to probe a little bit deeper, and that's the setting where I would start thinking about doing a hypercoagulable workup. And once I've determined what their risk is, taking all that into account, I would do the factor VIII and D dimer at the end of probably for a low to moderate risk PE, 6 months or so. For large PE, submassive PE, I would do at least 12 months of treatment. But at, let's say 6 months, I would do the factor VIII D dimer levels. And if they're normal, I would take them off of therapy and redraw the levels, watch them.
Okay. Another question we have from Hasmukh Prajapati is, do you use CT obstructive index in the decision of the treatment algorithm?
No, we don't.
Okay. Okay. And another question from Brad Hatfield. What is the role of catheter-directed thrombolysis or peripheral lysis in a patient like this for prevention of pulmonary hypertension?
So this patient straight to RV, even C3, although that was a non-gated study, but on echo he had moderate pulmonary hypertension. So really what we were thinking to do when we were considering thrombolysis at all in him, regardless of peripheral or catheter-directed, was to resolve that and reduce his 30-day mortality, which in the setting of RV dysfunction alone is doubled. But since his RV recovered so quickly within a couple days, and he normalized those RV pressures on his own, you know, we kind of lucked out, and we didn't have to lyse him. But I think had there been RV strain on the repeat echo, we likely would have.
Okay. And just one more question is from John Ryan. With regard to catheter-directed thrombolysis for bilateral PE, which method is better, placing an infusion catheter in the main pulmonary artery or placing the infusion catheter in each main pulmonary artery? I guess maybe in each side pulmonary artery, the right and left, or just in the main pulmonary artery?
I don't actually know that I can answer that, since I actually don't do those procedures at all.
Right.
So I don't think I can actually answer that. I will say that the Ultima trial delivered the thrombolysis dose to each pulmonary artery, right and left, and they gave it at a dose of 10 milligrams per lung.
Okay. Okay. Well, great. I think that's all for questions. Dr. Kadian, I just want to thank you again. That was excellent, and we really appreciate it. We'd love to have you back sometime.
Thank you very much. I really appreciate you guys having me back.